Are we live? Yes. Good morning, and thank you for joining the workshop with the title Frontline Multiplex Panel Testing and Reimbursement Challenges from Respiratory to Gastrointestinal. This workshop is being sponsored by Applied BioCode. Applied BioCode is an IVD company that is based in Santa Fe, California. The company has combined digital barcodes with molecular chemistry to create a bio-inspired barcode magnetic beads technology. The company designs, develops, and commercializes multiplex panels or multiplex testing. Before we start the workshop, I would like to invite a CEO of the company, Chris Bernard, to say hello to the audience.
Morning, everybody. I see everybody got the worm this morning. We appreciate you getting up early and showing up. You can tell Sajo's not a paid speaker. He had to read his intro off of his phone. Yeah. I see some familiar faces here, though, even maybe some Ohio State Buckeyes, so go Buckeyes this weekend. I'm told I had 30 seconds, so I'm going to cut this short. We're very excited about today's speaker, Dr. Pesko, Dr. Patel, and Dr. Beqaj, although it doesn't look like it's spelled that way. We've had a fantastic 2022. Really looking forward to 2023 as we basically are relaunching the company with our gastric panels and respiratory panels. So you're going to hear about gastric today. You're going to hear about COVID Flu Plus, which is obviously a hot topic right now. And then you're going to hear the money talk, right? You're going to hear about reimbursement and coding and how important that is, obviously, to each and every one of you. But some of the changes that have come down the pike, certainly changing every day, I might add. We've stayed up on all the latest and greatest, and hopefully we can share some insights with you as well. I've been here for about 10 months. It's been a fantastic ride so far. Look forward to the rest of the workshop. Please stop by and see us at the booth. We'll have plenty of folks. Just look for the people in the suits and the ties, and I'm sure we'll be able to answer your questions. But have a great morning. Thank you.
Thank you, Chris. Our first speaker is Dr. Kendra Pesko. Dr. Pesko received her PhD from University of New Mexico in biomedical sciences. She has been with Tricore for past 4 years and working on primarily in assay development and molecular infectious disease departments. Her talk will be value of multiplex molecular test in detecting most common GI pathogens. Allow me to welcome Dr. Pesko to present her talk.
Thank you, Sajo, and thank you to Applied BioCode for having me here today. Let's see. I can bring up the right presentation. I see it. Yeah, I'll get it for you. Sure. And thank you to you all for coming out this morning. I appreciate it. So I'd like to start by addressing what is syndromic testing. Syndromic testing actually is testing for a collection of symptoms and signs that a patient might present with. In terms of gastrointestinal illness, the symptoms include diarrhea, abdominal pain, stomach cramps, nausea, vomiting, and many of these pathogens are transmitted through a fecal-oral transmission cycle. The Applied BioCode GI pathogen panel is FDA cleared, and it includes testing for a number of different bacterial pathogens. Today, I'll focus primarily on the viral pathogens, so norovirus, adenovirus 4041, and rotavirus, and the parasite pathogens. At our lab in New Mexico, we already had molecular testing in place for many of the bacterial pathogens when we investigated bringing this platform in-house. So the biggest one of these, to my mind, is norovirus. How many of you have had the stomach flu or winter vomiting sickness? Raise your hands. Yeah, almost everyone's had this, right? Like, it's a very common affliction. These are just numbers in the US each year. There's 19 to 21 million total illnesses. And this results in a number of clinical visits, emergency department visits, hospitalizations, and even deaths. Norovirus is unique in that it's very winter-focused. That's why it's known as the winter vomiting sickness. You can see that in the couple of graphs that I have up here, just showing a peak of illness and outbreaks, primarily in the winter months. Rotavirus A is named rotavirus because it looks like a wheel, as depicted here. It's a double-stranded RNA virus, and it commonly afflicts children less than 5 years old. Fortunately, there are 2 very good vaccines for rotavirus that are used in about 70% of the population here in the US and given by the first birthday. So that prevents a lot of hospitalization from this disease, but it's still an important childhood cause of diarrhea. And then adenovirus 4041 causes gastroenteritis, primarily in young children and immune-compromised populations. It can be shed for a prolonged period, and it's different from those other 2 viruses in that it typically causes symptoms for a longer duration of time, and it's a DNA virus. This virus was actually part of a HAN from CDC earlier this year, investigating an outbreak of acute hepatitis in children. So adenovirus 4041 was associated with this outbreak, as well as adeno-associated virus. In terms of the parasite targets that we're interested in, there are 2 endemic parasitic infections that the Applied BioCode platform will detect. The first is Cryptosporidium species, and these are a little bit different from the viruses in that they have a summer seasonality. So cryptosporidiosis outbreaks are really associated primarily with pools and water parks. So don't swim with diarrhea. It's a bad idea. You'll spread it to everyone else. Cryptosporidium is actually incredibly hardy and resistant to decontamination with bleach. And so it persists very well in both pools and water parks. In New Mexico, we had a big outbreak in 2008 associated with an Olympic-sized pool and swimmers. So it's really an issue primarily in the summer and primarily due to the lack of disinfection of some of these pools and swimming areas. You can also get cryptosporidiosis from cattle and from childcare settings. So honestly, all of these fecal-oral transmitted pathogens are fairly common in childcare settings. Cryptosporidiosis is typically diagnosed through an OMP, or ovum parasite exam, and that looks at slides taken from stool and looking for oocysts of Cryptosporidium. So those are shown here in a wet mount on the far side in the left, and a trichrome stained mount in the middle, and also it fluoresces with modified acid-fast stain. They're around 5 microns in diameter. The other major endemic parasite that we look for is Giardia lamblia. This, again, tends to spike in the summer, and people are infected through an oral fecal transmission cycle, but there's a number of different mammals that can carry this parasite, including cattle, beaver. It's actually known as beaver fever. So campers, hikers typically can be exposed to bodies of water that are infected with Giardia during the summer months and ingest this. And typically you get symptoms after 1 or 2 weeks of infection. Often this is also asymptomatic. So it can cause diarrhea that is long-term, or it can be asymptomatic. And the last parasite of interest here is Entamoeba histolytica. This one is much less common, and it tends to be associated with travel outside of the United States. However, it's extremely pathogenic. It can lead to disseminated infections in the liver and brain, so it's an important organism to test for. The testing at our lab prior to bringing in-house the Applied BioCode instrument utilized ovum parasite examination as well. And the problem with that is that it's very difficult to tell apart Entamoeba histolytica from other non-pathogenic Entamoeba. You really are looking for the presence of red blood cells within a trophozoite to determine that it's actually the pathogenic version. And that's really a matter of luck, whether you happen to see that in the one stool sample where you actually detected Entamoeba or not. So I'll be giving results and comparing to our current in-house tests that we had available for these different pathogens. So prior to bringing in-house the Applied BioCode, which we did in 2020, we tested for rotavirus using an EIA, I think probably most people in this audience are familiar with EIAs. It's very similar to the process we use for testing for a COVID antigen, except in this case, we're using a little aliquot of stool in testing for the rotavirus antigen within a stool aliquot. So using these immunocard stat assays, it involves manual resulting, which always opens the door to transcription errors or other problems. And as we all probably are familiar, when comparing antigen testing for COVID against a molecular test for COVID, it has diminished sensitivity relative to a molecular test. For norovirus, we were using a send-out PCR, and it's a very good PCR test, but the problem with that is it's almost a 7-day turnaround time. So the delay in getting results really makes it difficult for providers, and maybe in a hospital setting for infection control, to act rapidly to control that infection. For GI parasites, most of our orders come in raw stool or stool and carry Blair for an O&P examination. Again, the ova and parasite examination is microscopy from either raw or preserved stool in a wet mount or in a stained slide. The CDC recommends, because of the limits in sensitivity, that you actually test 3 stool samples detected over 3 different days. So, this makes it logistically very difficult to perform this testing in a clinical lab. We would reflex our O&P orders for Giardia and Cryptosporidium, for those endemic parasites, to an EIA and a 96-well plate. That gave us greater sensitivity than the O&P examination, and an easier workflow than the O&P examination. But we were using this DSX liquid handler and trying to pipette from the stool samples into this liquid handler, which I believe was a pinch point for the technologists performing this testing. It was very difficult. Stool samples tend to be heterogeneous. They have a lot of different material in them, and so we would see clogging happen frequently in the instrument. They just have to watch it pipette, which I think can be very painful. So they were very happy when I started exploring the GI panel as a possible replacement test for this. So the GI panel from Applied BioCode can be used on both stool and carry Blair and raw stool, shown up here. You take an aliquot of that stool and put it into a tube that has a stool recovery buffer and some beads to homogenize it. So you want to break up all the stool material as much as possible using this vortexer. Spin it down briefly and then pipette off, and there are 2 different cleared platforms for automated DNA RNA extraction. The EasyMag, which I believe is being sunsetted in the next couple of years, and then MagNA 96 that we currently use in our lab. You set up PCR after extraction is complete, load everything onto the instrument, and it performs an automated PCR, hybridization, detection, and then you can report your results directly from the instrument. So this is the technology. There's a PCR that occurs with a 5' biotinylated primer on one side. The PCR products are denatured and mixed with probes that have a barcoded magnetic bead. That's the specific Applied BioCode beads. These are just like barcodes you would use at a grocery store, but very, very, very small. It's mixed with streptavidin and phycoerythrin, and so that generates a fluorescent signal. And the bright field and the fluorescent images become overlaid in order to generate a fluorescent signal for a positive or negative reaction, and then scan the barcode to see what exactly the target is. So the workflow and the time to results for this, it takes around 7 hours to perform a 96-well plate, around 80 minutes to set up all those samples and extract from them, 70 minutes for the extraction to occur. You spend maybe 30 minutes setting up the PCR and the instrument, and then it takes around 3.5 hours for the instrument to perform PCR target capture, signal generation, detection, and then you can result directly from the instrument. So we performed our validation in 2019 and 2020. We compared the crypto and Giardia detection against our EIA. We compared Entamoeba histolytica detection against O&P results. The rotavirus A was compared against the Meridian immunocard stat. And our norovirus G1, G2 results were compared against the send-out PCR and the results from our state lab. And we used the BD-MAX to resolve discordance. We already were using the BD-MAX for some of the stool pathogen testing for bacterial targets, and we were concurrently exploring it as an option for viral and parasite detection. So this is what we found. We have very good concordance for some of the targets, like Cryptosporidium and norovirus. We found fairly poor concordance for Giardia and rotavirus, but on second look, we found that we had many false positives being produced by the EIA for both Giardia and rotavirus, as was confirmed by negative testing on both the BD-MAX and the applied BioCode. So these are our adjudicated results. Overall, we found the performance of the applied BioCode instrument was better than our current in-house methodologies, and that moved us forward towards adopting it and implementing it as a solution for detection of these pathogens. So at Tricore, we actually divided the GI pathogen panel into two smaller orderable panels based on the viral targets or the parasite targets because of the differences in seasonality and some slight differences in presentation from patients that are infected with the parasites or the viral targets. And so these are two different orderables that use the same process, the same workflow, and we mask the results based on what's been ordered. So this is an example of a report from the applied BioCode. We mask all of the bacterial targets because we are not reporting out any of the bacterial targets from this instrument, but we're able to pull in orders based on either the parasite or the viral panels and release the results that are pertinent to those orders. So that's shown here at the bottom. So what about invalids? I don't know if anyone here has dealt with stool in a clinical setting. Invalids are a huge problem, right? It's a heterogeneous sample type. For molecular testing, it's inhibitory frequently, so that's why we do have those upfront dilution steps. Our average invalid rate with this platform is around 5 to 10%. We reflex invalids to a repeat that was validated based on the package insert, so a 1 to 4 dilution into star buffer. And fortunately for us, most of them resolve after a repeat. So this is just a table showing our invalid rate for the first 6 months of this year. Out of around 4,000 samples, we had 225 that were invalid on the first run. 75 of those actually were invalid when run a second time with this additional dilution step. So our overall invalid rate is less than 3%, which for stool is pretty good. So I just wanted to address some of the benefits that we've had from the switch from OMP and EIAs to the molecular panels. We believe we're providing more accurate test results to our providers, which is a benefit, right? It's more confidence in our results overall. We've seen a decrease in turnaround time, especially for those tests that are like the OMP that's only performed 1 time per week at our lab, or for a send-out test where it takes almost 7 days to come back. We enjoy the interfaced reporting, so being able to report directly from the instrument, it eases the process for our technologists, and it also prevents any transcription errors when reporting. And the easier workflow overall, it's easier to train new technologists. And with that, I'll complete my talk. I think we'll wait for questions till the end, but I'd like to welcome Dr. Anami Patel. He will discuss the implementation of the SARS-CoV-2 Flu Plus assay at his lab. He's coming from PathAI Diagnostics?
Yes.
Yes, and yeah, without further ado, Dr. Patel.
Thank you, Dr. Pesko. Uh-oh.
Well, here's yours, right?
Yeah.
presentation view?
Thank you. Thank you. This was a good overview and looking at the data on applied BioCode GPP panel, especially angle on viral and parasite targets. So at PathAI Diagnostics, at my lab, we have implemented this test, what Dr. Pesko talked about, for several years now. And their FDA approval is on raw stool and Carrie-Blair. We have validated on rectal swab specimen, and so it's off-label product, and that works equally well. So I just wanted to add that. So, well, thank you, Applied BioCode, for inviting me to share our experience at PathAI Diagnostics for COVID-2 flu plus assay, which is designed for influenza A, influenza B, RSV, and COVID. So 4-plex on their MDX 3000 instrument. And they had approval late in 2021, so we were able to validate immediately and just be prepared for that season. And we all know what happened in 21 around the flu combo test. So first, just little introduction for my company. I work for PathAI Diagnostics, and I can see here. Nope. No.
Let's close it.
There we go.
Okay, let's try one more time.
It should go by this.
This one?
Yep. Yep, thank you, Parisa. So so PathAI Diagnostics, we are full-service anatomic and molecular pathology lab based in Memphis, Tennessee. We have 4 main divisions, GI, derm path, urology, and women's health. And for most of our tests, 90% of the time, we give out results within 72 hours. And we are space-wise 30,000 square feet space in Memphis, and we do about 15,000 plus assay. They may include like different syndromic panels and along with antibiotic resistance. So with that, I think today's objective is Applied BioCode has this FDA approval as EUA on their flu COVID assay on label as MagNA and EasyMag. Many of the labs, they don't have either MagNA or EasyMag, so what they do about it, right, for the extraction part. So that's what we looked into it. We happen to have MagNA as well as KingFisher instrument. So for this objective, we looked into the same samples, frozen samples, each of influenza A, B, RSV, and COVID, extract same time on both extraction platform and go downstream on 3000 system. So that's the data I want to show you. So here is just the workflow, testing workflow, extraction on either both of those instruments, and then we set up PCR plate and goes on 3000 system. Again, Dr. Pesko has explained very nicely about the applied BioCode technology, barcode technology. So they have very tiny particles, which is barcode and attached to 5'. And then for the detection part, they captured with biotinylated RT-PCR product amplicon, and that process is very quick and very sensitive. The greatest benefit of this BMB technology is we can do highly multiplex on a 96-well plate format, which is designed for 3000 system. So in this assay, particular assay, even though there are 4 different viruses, but for influenza A, they cover 3 different strains of A, influenza A. So just to compare between MagNA Pure and KingFisher instrument, we first looked at the analytical, how it performs between two in terms of sensitivity, so limit of detection. So what we did, we purchased Zaptometrics panel with pre-quantified viral particle for each of this, SARS-CoV-2, influenza B, RSV, and 3 different strains of influenza A, like listed here, H1N1 seasonal, and then 2008 H1N1 pandemic, and H3N2. And I'm going to show you the data of limit of detection comparing between Roche MagNA Pure and KingFisher instrument. So as we can look at here, we made the serial dilution, and then we found the range where we lose the detection on each of this strain, and then just above that dilution, we did 20 replicates of each of this. And again, the material was from Zaptometrics, going through the MagNA Pure as well as KingFisher. So easily we can see here, they are comparable on both instruments. We were able to see a little better performance on KingFisher Flax instrument for one of the strain of influenza. Otherwise, it was very comparable between 2 extractions. So then we wanted to look at clinical evaluation, how clinical agreement. So we were able to go back into our freezer before pandemic time, and luckily we had somewhere from 30 to 60 samples archived, influenza A, influenza B, RSV, and COVID samples. COVID samples during pandemic. So here I have just listed for influenza A, we had 30 positive samples, B, we had 43, and RSV 30, and COVID 60 positive. And we also looked into SARS-CoV-2 negative samples, frozen samples. And each of these samples were same time thawed, aliquoted in 2 different workflow, one for MagNA Pure and another for KingFisher. So as much as possible, we didn't want to introduce any variable that one day you do this and second day. So this happened on the same day. So looking at the data, probably it looks a little bit boring here. We were able to get clinical agreement for influenza A and influenza B, 100% agreement for the detection part. Remember, this is qualitative assay, so we didn't get into CT value. And applied BioCode system doesn't give the CT value, so it has MFI value, which is not quantitative. We saw some difference in RSV, archived frozen specimens. So we used 30 specimens, and we were able to get agreement on the 28 samples were positive on 96 MagNA Pure and 29 on KingFisher. And 1 sample was internal control fail on MagNA Pure. So that is why. And again, this internal control is a spike MS2. So it's not endogenous control. And we continued with our SARS-CoV-2 positive as well as negative samples. So on 60 COVID samples, these samples were saline, and they matched very well, all positive samples, 100% agreement. On the negative samples, KingFisher was able to pick up 2 more specimens as positive. Again, don't know, and this comparator method was Roche cobas 6800. So we knew the CT value, they were negative on cobas, whereas on MagNA Pure, it was not detected, and KingFisher was able to detect. Hard to know whether they were low positive or not. So here, just bar graph comparing side by side in the red bar, total number of specimens, and blue and green color, MagNA Pure and KingFisher. So they fare very well to each other. So when we do not have access to MagNA Pure, which is on-label test as FDA, EUA, how do we deal with other platform? So in this case, KingFisher. So both instruments, MagNA Pure as well as KingFisher, they perform very well. So let's look at the extraction and the entire workflow between two. So again, sample type is either VTM, UTM, VTM, or saline here. Sample input volume was same between both workflows, 200 microliter. And the elution volume was also same, 50 microliter. And total processing time, like Dr. Pesko mentioned about MagNA Pure on one of our data, it takes about 50 minutes, whereas KingFisher takes less than 25 minutes. So we achieve a little bit time there. And hands-on time, up to 45 minutes on MagNA Pure to set up the entire plate manually. And on KingFisher is about the same, 30 to 60 minutes. And then total number of reaction, the number I put here, 576. If I'm doing MagNA Pure extraction all day long, one shift, so we can do close to 600 samples a day on one MagNA Pure instruments. Whereas KingFisher, being so quick, 30 minutes, we can go up to 1,000 extraction per day on one KingFisher Flex instrument. And there is a catalog number for each of those two instruments. So in conclusion, we at PathAI, we tested both Thermo Fisher KingFisher Flex instrument for the extraction and MagNA Pure, and we were able to see the data. They were acceptable for KingFisher, that we are not compromising any sensitivity or clinical agreement based on the data I showed. And then performance of the KingFisher Flex and MagNA Pure, efficiency-wise, while we saw the LOD on KingFisher is slightly better than MagNA Pure. Happy to take question after Dr. Sajo talk. So thank you.
Thank you, Anami. Do I have to open my slides? Yeah.
Yes, yes, sir. Here. You just come on up here.
Yeah, that's right.
Close this.
Very good. Thank you. Thank you all for coming to the workshop. Thank you, BioCode, for inviting me to present today on a very important topic. My talk will be on molecular syndromic panel billing and reimbursement. We are all here who works in the lab, we are providers. We provide services to our clients and patients, and of course, for services, we look to be reimbursed or to be paid. And there are two payers that we deal with, governmental payers and then private payers. Most of the time, governmental payers, which is Medicare or Medicaid, and now they have also MACs, which stands for Medicare Administrative Contractors, who actually process the billing and for Medicare, but they usually Medicare would come with the policies for coverage. We call them local coverage determination, and then adapt, and most of the private payers would adapt those policies later on. Yeah, so the topic will be on reimbursement based on LCDs or articles published in effective 2022 October 1st. Kendra, Let's do one more time.
It's not switching. Okay, let's just. I don't know why it's doing this.
Yeah, that's good.
You want to try to see which switches?
Nope.
I don't
Maybe
know.
try this one, hold on.
Yeah, try.
Nope. I think it has to do with the...
Kevin, can you give us? Oh, no, I don't think it's, this one?
Yeah, that one. Now let's try.
Try again.
Try again.
There we
Yeah, that's good. Okay. Sorry about that. So anyways, Kendra already explained what molecular syndromic panel means. We were a long time ago, probably Steve Young and me, that we are older, remembering we were seeking and asking for multiplex panels because it makes a lot easier for the lab and for the payers and to get paid. And finally, we come to the point that we have now multiplex or multi-syndromic panel, which is based on, like Kendra said, on symptoms, sites, and targets. So practically, let's say when you say respiratory pathogen panel, then you know that site is respiratory, specimen or symptoms are respiratory and so on, but targets used for detection or diagnosis of that infection also matter. So in this case, syndromic panel is multiplex testing that has more than one plex or target in the panel and is based on sites and then symptoms. Usually are designed to replace the culture, and most likely pathogens selected in that panel will be very specific to sites to replace the culture, and most common pathogens that probably covers a cause of that infection more than 4 or 5%, I would say, or better. But anyways, it is very good actually for labs because molecular syndromic panel can include in the panel viral targets, parasitic targets, fungal targets, bacterial targets, and even some antibiotic resistant, and all could be done in like within hours. So it's a very good tool for physician to diagnose and manage the disease rather than wait for culture 3 to 4 days or 5 days. So for example, for respiratory culture, you have to wait maybe weeks or for fungal culture. So very advantageous, a very good tool for laboratorians to provide results and help, or tool to provide to providers to diagnose the disease and manage it. Now, although very exciting about that, they still have to meet the medical necessity, meaning you have to submit the right unit or CPT code and right diagnostic code, otherwise these policies will not cover. So this is what we're going to talk today. And there are about 7 multiplex or syndromic panel covered by this new LCD or article published in 2022 on October 1st. And those are most common, like bloodstream infectious pathogen panel, which is a sepsis panel, mostly hospital-based panel, and the respiratory pathogen panel and pneumonia panel, then gastrointestinal pathogen panel, meningitis or encephalitis panel, and urogenital panels, which includes bacterial vaginosis and yeast and vaginitis. These are the 7 panels that they have their own coverage and CPT code, and then most likely we will have also, hopefully, approved for urinary tract infection pathogen panel, wound care pathogen panel, and nail fungal infection pathogen panel. These 3 panels, I'll show it to you, they are not currently covered, and but we hope that will be covered one day by these LCDs. This is the list of the panels that I said that are covered, and honestly, the articles or LCD were published by CPS, WPS, Noridian, and Palmetto BA. However, as you know, after they publish and use these LCDs, most likely other MACs will pick up and utilize these policies, and most likely even the private payers will utilize these policies. So even if you are in Novartis, for example, area, and they don't apply, this doesn't apply, most likely expect in 1 year or so, they'll probably use these LCDs to cover, yeah? Now, again, every panel has its own specific CPT code based on number of targets, site, and also symptoms. So respiratory will have specific CPT code for respiratory, and based on targets, they have 3 different CPT codes. When you build, you have to build 1 unit per panel for the intent of use or for the indication. And you cannot unbundle, and don't try to unbundle the panel. You cannot say respiratory pathogen panel, you build and then say, oh yeah, Mycoplasma pneumonia has a separate CPT code, I'll submit that. That's against the law, you cannot do that. As long as you run that panel, you have to use only 1 code, and if it's a less than 5, you use the code less than 5. If it's a greater or more than 5, you use that code. And of course, you use the ICD-10 all the time to cover the diagnosis or reason for ordering. If you don't want to use multiplex panel code and you have a laboratory developed test, then you would use 8799, which is a general code, unlisted molecular code for infectious disease. Then you have to apply for Z code, and then you have to use a modifier 59, and you can, I'll show it to you, you cannot build more than 20 units anyways. But regardless of what you do, it's very important that this is very, I think this is how I understand how we practice. If you run a less than 5 pathogen panel and you submit the CPT code, that's compliance. But you cannot run the extended panel and submit the less than 5 CPT code panel. That's called induction, which means you induce in the physician to get more for less. That's against the law. Actually, that's very careful. A lot of labs will say, oh, I just run an extended panel and bill for the for less than 5 CPT codes. That's still against the law. So you could run maybe extended panel and block the other agents and then bill 5 pathogens. Whatever you report, remember, you submit the requisition and report for the billing. So they see whatever you report, they will know that you have run it more than 5 panels. Yeah? All right. Who can order molecular syndromic panel? So these are the policies that this MACs and also Medicare has adapted. And honestly, when we got this LCD, we were disappointed, but when you look into it, it is not that bad. And I tell you why. Now, less than 5 pathogens, a respiratory pathogen panel, or less than 11 pathogens GI panel, everybody can order. Primary physician, family care, ER, hospital-based, nurse, physician. So it's not bad. So at least you know that less than 5, everybody can order, put it, write ICD-10, it will be reimbursed. Now, greater than 5, they made the rule that you can only specialty physician can order. In case of respiratory, pulmonologist or infectious disease for immunocompetent patient has to be ordering physician. And same thing with gastrointestinal panel, GI specialist or infectious disease could order the panel. Now, exceptions are in a rural area where the specialist is hard to or they are not available, then you can, but you need to document that, and it really involves a lot of audits and all that. But larger panel, or we call it extended panel, has to be ordered by specialists. And for the immunocompromised patients, in addition to specialists, the transplant physician, or oncology and specialist physicians can order the panel. Yeah. Now, you can order 1 panel per day on a date of services for the same intent of use. You cannot order 2 panels for the same day. And if you order, you have to submit the 59 modifier to explain why did you order a second panel for that day, for next day or that day for the same intent of use. You probably all heard about MultipleX. MultipleX program was developed by Palmetto GBA in 2011 to really establish the coverage for molecular diagnostic tests and laboratory developed tests. This program is provided for 28 states across the Medicare administrative contractors, or MACs, and there are 4 of those, CGES, Noridian, Palmetto GBA, and WPS. Now, although these MACs have their own policies and procedures and require Z code and all that, most of the policies that are published will most likely be adapted by other MACs or other regions. The MolDX will require that you apply for Z-code. Z-code is an identifier code for your lab. You still have to submit the CPT code and ICD-10, but when it's approved, then you have no problem for reimbursement of that test. Now, who or what test requires Z-code? FDA-approved test, if you follow the manufacturer's instructions and you don't modify or change the test, don't require the Z-code. Most of the FDA-approved but modified tests or laboratory-developed tests will require Z-code. This I'm talking about infectious disease test or syndromic panel, and then test reporting with the tier 1 and tier 2, which more applies to the genetic testing. Yeah. And again, FDA-approved test will, if you perform following the FDA approval, then you don't need the Z-code. To apply for the Z-code, and I can see Jerome is here, we applied many times for our lab to get a Z-code. It is a really process, but when you get that approval, at least you know you're going to be reimbursed. So in this case, you go to their webpage, you register your lab, and then you will get the login credentials, maybe 2 to 10 days. And then after that, you have to add the test. Now, adding the test is a procedure. You really need to submit all information about the test, and it will take 2 to 3 weeks to get a response to submit a technical assessment, or TA. And TA, you have 15 days to submit. And then, honestly, I would recommend you be very ready before you get that request to submit the TA, because it's a big process. Yeah, so have all elements in place before you submit the form. Yeah, and then
There is a timeline, right?
yeah, there's the timeline. After you submit the TA, it might take, how long it will take, Jerome? 5-6 weeks to get, or something like that? Yeah, yeah, yeah. So technical assessment is very important, and I tell you, we all do a good validation. And as you know, I don't need to tell you, it's a basic. For FDA-approved test, you need the verification. So you follow the guidelines, CLSI guidelines, and you verify, and you're done. And most likely, or not at all, you will be required to submit the TA for FDA-approved test. If it's a modified or LDT, because if you modify the FDA-approved test, still becomes LDT. Although it's a lot easier because you maybe change the collection device or sample collection, you kind of could make a better case. But either way, you have to do a good validation. If you don't perform a good validation, they will reject your Z-code. And good validation means you have to follow the CLSI documents, and there's a publication that they require you to read, published in 2010, and the publication is on validation of molecular, laboratory-developed molecular assay for infectious disease by Elaine Bart. That's what they require you to read before you submit, so you need that. But anyways, as we all do, we do accuracy, analytical sensitivity, analytical specificity, precision. We publish the quality control, quality management, and all that. Remember, LDTs and MolDX will not require you to do the clinical study. If you could, it would be better, easier to approve, but if you don't have to, it's not mandatory, as long as you have a good publication to back up the intent of use or clinical utility of your test. Remember, your LDT, your clinical utility, those are your claims. If you say this test is intent of use for diagnosis or respiratory infection, that's your claim. You have to back up that either by publications or do the clinical study. So, but it's not mandatory. In accuracy, it's very important that you use enough samples for correlation and not to use unmodified samples. You have to use really patient samples and not to modify. And if possible, to cover all the pathogens or targets from those patients. When you correlate, they prefer that you correlate to the FDA-approved reference method. So for example, if you do the LDT and you correlate to their method, they prefer that, and you would have to submit the IFU of that reference method or package insert. Now, you also must say the laboratory that you use as a reference method and the clear number, because I guess they check that, yeah? And then if you have to modify the specimen, meaning you cannot cover all pathogens, and you have to spike them, don't modify the specimens. Confirm the negative and then spike with a ATCC cell line or whatever, but and clearly state which were not modified and which were spiked and how many they were spiked and what was the reason to spike. Very nice summary, otherwise they will not accept it. You have to really have a good summary, like a publication, for them to really approve you. And analytical sensitivity, if the assay requires LOD, LOQ, or linearity, you do it following the CLSI document, otherwise they will not accept it. And same thing with specificity. You have to really do the cross-reactivity of your primers and probe check to show that doesn't interact with the similar pathogens of that site. And also, it's important that you do the interference of that site, if it's, let's say, blood or whatever, but some interference based on CLSI document. Otherwise, they would not accept that too, yeah. And then precision, of course, you follow the CLSI document. You make sure that you state what controls you use, and if there's any rule, which one is positive, which one negative, and so that stated very well. But, of course, you would state positive, negative, and NTC, whatever the controls are used, and then quality management, how you prevent the contamination, all that. And at the end, you will have to do the CPT code submission. Anyways, at the end, you have to write a nice summary, validation summary. Very clean, easy to read with tables. This is how many specimens I did. This is what I did. This is expectation, meet your expectation or not. Very, very good summary, validation summary. And then also submit the executive summary where you state everything about the test, validation, reporting, and all that. And you will have to submit report, sample report, requisition, SOP, which is your IFU for the test, and supportive literature, best supportive literature. Not just go to PubMed and find the papers. Honestly, best supportive literature. Otherwise, they will not. They will read the literature, or they know the literature, actually, yeah? And then you will have to have, at the end, gap fill-in, which means put the CPT codes and the pricing that you trying to get a Z code for, yeah? So that's about the Z code application. And more information could be really found to MultipleX.com. But quickly, I'm going to go through the CPT codes for syndromic panels. These are the non-FDA syndromic panels that currently you have to use the 8799 code and modifier 59. You cannot build more than 12 units anyways. So it comes pretty much to same price to the multiplex greater than 5 targets, yeah? And same with wound care, same with the nail fungal infection. These are the CPT codes used for other molecular syndromic panel, for meningoencephalitis panel, bloodstream infection, and urogenital bacterial vaginosis and vaginitis. But also, I can provide these slides. These are really from the Medicare. These are the CPT codes that you need to use and submit. The main thing is really when to use which one and how to, who orders the code. And these are the most of the codes that you can use for GPP, for gastrointestinal and respiratory, less than 5 targets. There are some LPAs, like you can see 0241U, those are proprietary or temporary codes, and all of them are reimbursable. Then you have to decide which one to use. These are the CPT codes for syndromic panels for respiratory and pneumonia, and for gastrointestinal, more than 5 targets. And with the price at the end, you can see here. You have to be very careful what you submit, definitely. And then these are the extended codes that reimburses $416 based on that. And of course, that is dependent on the site, symptoms, and targets. So better make sure that is ordered by the right specialty if it's extended panel and the right ICD-10 code, yeah. In summary, syndromic panels have the ability to impact the infection control, antimicrobial stewardship, and patient outcome by significantly reducing the time to diagnosis and management. There are 7 molecular syndromic panels that are approved by CMS or managed care, and we went through those. And each panel has its own specific CPT codes, which is based on targets, sites, and symptoms, and clinical utility and medical necessity, and fee schedule varies based on number of targets and symptoms and ICD-10 or diagnostic code submitted. Now, my message from this talk is really look for the FDA-approved test is available before you really go develop the laboratory-developed test, because it's a lot of work and you really face some difficulty to get paid for it. If there's no FDA-approved test, of course we have to go with the LDT, and we'll continue developing good diagnostic tests, and we hope that even the other 3 panels that labs using right now for UTI and wound care and nail, hopefully we'll get an FDA approval from our medical device companies that we work with and get a good CPT code for reimbursement. Again, thank you again for the attention. I think the question section could start now, yeah. Thank you.
And I know everybody's going to ask, all these slides will be on our website. I saw everybody taking pictures, and real quick, you can go to our website, pull down all the speaker presentations. Thank you.
That on? Yeah, there we go. Thank you. Very nice talks. So I'll start with the last first. What about the joint infection panel that is FDA cleared? I did not see that mentioned. Do you know what the status of the joint infection panel is? And then along the similar lines for the Z codes, I thought MolDX was not allowing contrived samples as part of the validation.
For the joint panel, I'm not sure. I didn't
I
really
do.
look into it.
I'm with BioFire. It's FDA cleared.
I know it's FDA cleared,
But these are the panels that LCD published by MolDX Max covers. I couldn't find that panel. In regard to contrived specimens, actually they allow you have to explain what is the reason you're using it and what are you using and how you use it. For example, they say use the patient specimens, but don't modify the metrics. You can spike them with make them contrived and explain it why and how many, and was that beating your expectation? Yes, you're right. They prefer not to use contrived specimens, but definitely they do. Actually, it says in the recommendation, yeah.
So we did that, but they said no, they want clinical sample. And how come you are going to get if you have RPP 24 pathogens, nowhere in the world you can get that.
No, you go to their, actually, believe it or not, you can set up a meeting. We set up the meeting with my lab. It's like a hearing. They have like 10 scientists, and we have our scientists. Then we ask this question, and they said actually, we don't prefer that you use contrived specimens, but if you cannot cover all the targets, you have to show that you can cover, so you can spike the specimens. And even in the talk, when we talked to them, actually, they gave us a very good tips, very good advice. She actually, the main lady, can't remember her name, she said, oh, no, you just said we compared with UltimateDx. That doesn't mean nothing to me, she said. You have to say what lab, clear number, and what method that lab uses, and send the packages. Very, very detailed, I can tell you that, yeah.
Yeah, because we submitted and they said that no, we need clinical sample. We said that we work based on the publication that
I mean, they will try to make you to get specimens for all the targets, which is really hard to do it, like for 20 targets. Yeah. Similar with the PGX, pharmacogenetics. How do you cover 120 variations? They allow us to do the contrived specimens. We do spike them, or we use a Coriell samples, yeah?
One more question. So did you try also the extractionless with the flu?
Yeah, that I was going to mention about it. We all know how well on COVID extractionless is working. I'm very, very curious why we need to worry about FDA approved extraction or not, and just try without extraction. But we have not for flu and RSV. Yeah.
Because I have developed that my flu panel and it's totally extractionless.
And it works good?
100%.
Applied Biosystem, yeah. Yeah, I'm not surprised. We just don't have that data, yeah. Very good point.